Diagnosis in Lacanian theory. This is the third session in our series of talks on diagnosis in Lacanian psychoanalysis, and I've given it the title Diagnosis Through Speech. We'll also be involving the idea of diagnosis via the notion of the big other. So just before we begin those levels of discussion, let's just link up to what we had said towards the beginning of the last sessions. And one of the points we tried to make there was to ask the question, what is the diagnosis even aimed at? Now, presumably the answer would be, well, at the people that are coming to the clinic. But we could say, trying to refine the point a little bit more, diagnosis shouldn't be an objectifying type of language. Diagnosis should rather be, we could put it this way, as existing for the purposes of technique. Diagnosis for strategy. Diagnosis so as to direct the treatment. Diagnosis, we could even say, as a way of orienting ourselves in the transference to work more effectively with different types of patients. We diagnose so as to decide on the technique that would be most effective in the clinical work. In many of the lectures that follow, I will elaborate on this point, but let's just say it here. We've already intimated the idea that Lacanian psychoanalysis is not one mode of clinical work. Diagnosis will tell us that there's different types of subjective structure and that we need to take on very different orientations to the clinical work. So to put the point very bluntly, in Lacanian theory, the clinic of neurosis is completely different to the clinic of psychosis. The way the analyst positions themselves to do the work, the way they listen, their orientation, the techniques they use, the direction of the treatment, all of these things will be different. You could say, if we had to imagine wearing a little disguise, that you go to the same Lacanian analyst presenting as psychotically structured on one day and presenting as neurotically structured on the other day, they should work with you in such different ways that it's hard to even believe it's the same clinician. Okay, I slightly exaggerate, but that's important. There's a dramatically different orientation to the clinical work depending on how the person presents and how the person is structured. So that was the first introductory comment that I wanted to make just before we move on. The second is to say that I made these points on the board just towards the end of our last sessions, two aligned points. There is no structure for normality in Lacanian psychoanalysis. There is no structure for normality because all subjects will find their location somewhere within the structures that we have discussed and described. And moreover, we could say, maybe bending that point somewhat, we should also bear in mind that there's no default diagnosis. Now, this sometimes comes up in clinical discussions. Someone would say something like, well, the person hasn't evinced any overtly perverse symptoms or behaviors, and likewise, I'm not picking up any sense that there's something psychotically structured about this person. Hence, they are neurotic. I would argue that that's not quite good enough. You need a kind of differential diagnosis, and by differential diagnosis, what we're suggesting is you need both good evidence that someone's not perverse and that they are, let's say, obsessional neurotic. So you need two forms of evidence before you can be relatively secure in the kind of diagnostic structure that you're referring to. So I suppose we should also develop that and say it's not the case that, here's another one. There's often a slippage, it seems to me, in Lacanian terminology between, oh, well, let's say, for example, there's a woman who's come to my clinic, she seems neurotic, therefore she's hysterical, right? This idea that somehow hysterical and femininity go together and obsessionality and masculinity go together. It may well be that in many case studies, and maybe there is some close association between those two things, sexuation in Lacanian terms and those clinical structures, but one shouldn't by default say, well, someone doesn't present as psychotic, therefore they're normal, therefore they seem to be obsessional, hysterical, they seem to be neurotic. One wants to have good evidence, a good sense of that someone, via differential diagnosis, is neurotic, rather than using that as a default category. And by the same token, one wouldn't want to say, well, someone seems to be neurotic, she's a woman, therefore she's hysterical. You want to have good differential diagnostic evidence to suggest that she is hysterical and not obsessional for these reasons. Okay, so those are two crucial elements to reiterate. And then in the last couple of sessions, I did mention Sergio Benvenuto's book, Conversations with Lacan. So just a very brief quote to help pull together some of the points that we've made before we move on to the question of diagnosis via speech. Lacan too, says Benvenuto on page 125. Lacan too does not think in terms of illness or disorders, but in terms of subjective structures. This means that you can have a neurotic or psychotic structure, but not actually develop any apparent neurotic or psychotic clinical symptoms. Nice point. We've already differentiated between structure and symptoms, and now we're saying that any one of those structures is a place where you can find your, as it were, subjective arrangement, your location, without being necessarily symptomatic. Another way of putting the same point is to suggest that you can be psychotically structured without being psychopathologically psychotic, without suffering the symptoms of psychosis. You can be neurotically structured, this I think is kind of me, by the way, obsessionally structured without suffering the overbearing stasis and qualities of suspension and petrification, which sometimes go along with more pathological forms of obsessionality. You needn't be suffering the symptoms of that structure to be within that structure. Just one more comment by Sergio Benvenuto. He notes that, interesting point for me at least, Lacanians accept some post-Freudian diagnosis. For example, autism, eating disorders, and addictions. They mistrust the now fashionable category of bipolar syndrome, and they do not accept the very popular category of borderline personality. So this is a well-known fact. This is a well-known fact that borderline personality is not something that Lacanians recognize. You could argue, as some Lacanians do, who's borderline, the clinician or the person? Presumably, the idea would be borderline means one's not quite able to decide. And for the Lacanian clinic, you need to be able to get some sense, you need to be able to decide before you start the clinical work in earnest. Benvenuto also wants to go on to argue, at least in his sense, in his mind, that what's often thought of as borderline personality disorder would often tend to be, such as his argument, hysterical neurotic structure, not its own standalone diagnosis. So just wanted to make that point. He also uses the idea of subjective arrangement, which I like. He doesn't just talk about subjective structures, but subjective arrangement, which I think gives us a nice sense of the variation within those structures. Okay, so we've made those points. I suppose I'll just add my one thought to that. Yes, eating disorders, addictions, you could even say depression, but the important point here is not that those are differential diagnostic criteria. Rather, there are descriptions which you might want to add onto your clinical judgment of whether you're dealing with which structure you're dealing with. So one might talk about, for example, neurotic structure with depressive features, but one wouldn't want to say depression as the primary diagnostic indicator. Okay, so let's now move to the question of various forms of doing diagnosis in Lacanian psychoanalytic work. And you could say, given that we've spent so much time emphasizing that Lacan's all about speech, about the symbolic, about the signifier, you could say one place that we should start, one area where you would be able to do the work of diagnosis would be precisely through attending to the speech of the patients, of the clinical work. And I think one person who does a really nice job of being able to describe this and highlight the various facets of speech within transference of speech within clinical work is Dany Nobus. This is his 2000 book, Jacques Lacan and the Freudian Practice of Psychoanalysis, and we're going to read a few quotes from it as we develop this idea of how diagnosis might work through speech. One further proviso, just before we move on to say that, one should also bear in mind that I've spoken about, as it were, the time of diagnosis, the period in which the kind of diagnosis happens. And I should just add the obvious point. Maybe it seems obvious to Lacanians because it's so much part of their practice that they forget to mention it. Freud himself speaks about a kind of set of preliminary sessions. For Freud, it's not very long, maybe it's a week or two before you settle on a diagnosis. In Lacanian theory, the preliminary sessions can stretch out for a much longer period. these preliminary sessions are kind of like a type of interview, and the clinical psychoanalytic work has not yet begun in earnest. And the reason that you have these preliminary sessions is precisely so as to get a sense of what general diagnostic structure one might be working with. That also then means that the preliminary sessions can be extended. They can go on, not just a week or 2 weeks or a month or 2 months or a month or 3 or 4, can go on as long as that. They can go on perhaps even as long as a period of a year before the proper clinical psychoanalytic work starts. That may sound a little odd, but the reason for that is that sometimes a clinical diagnosis, a sense of the structure, the subjective arrangement one is working with, is not completely obvious, is not completely clear. And for that reason, you could say that there's a good logical and ethical reason that those preliminary sessions should go on for as long as it takes the clinician to have a good sense of whether they are dealing with perversion, whether they're dealing with psychosis, or whether they are dealing with neurosis. And moreover, the reason that it is so important to have a good sense of which of those structures you are working with is because you would work fundamentally differently, particularly with those structures of neurosis and psychosis. So let's then turn to this point. How might we go about thinking of diagnosis through speech? Well, the first comment that Dany Nobus gives us is no surprise. We know a little bit about psychoanalysis by now. Is he says that when neurotics start to speak, they cannot prevent themselves from conveying more than they intended. Their words do not fully capture what they want to say, or they express too much. And I think he's got a nice way of evoking this kind of vacillation in the speech of neurotic subjects. The speech of neurotic subjects seems to move in these two different directions. Number one, I end up saying much more than I thought I would by conveying intentions, implications that I hadn't hoped to convey. And also I get that sense sometimes that I haven't quite been able to say exactly what I mean. So we get both of those variations, saying much more, the words over-speaking me, you could say, saying much more than I intended, particularly in nervous situations when it seems the big other is present. And also that sense that I'm never quite able to capture it all. I'm never quite able to perfectly encapsulate the actual underlying motives, agendas, and ideas that I have. So that says something about the speech of the neurotic. Now, by contrast, speech seems to be somewhat different in psychotic subjects. And again, just to be careful, although I'm generalizing here, we'd maybe want to be a bit more precise in terms of some of the points being made here. Let's think about the speech that we might find in the language, the spoken interactions of, say, for example, schizophrenic people. That speech will have a slightly different quality, argues Lacan. Now, immediately we should make another proviso. Lacan, certainly around the time of Seminar 3, is insistent. He says, listen to the relationship the subject has to speech. Attend to the relationship that the subject has to their speech. And I think that's really important. You could say neurotic people are aware of how their speech might have implicated them, how they may have said something that's embarrassing or whatever. Maybe that's not quite the same in the speech of psychotic people. Maybe their relationship to speech is somewhat different. So that's I think the important question. How is the relationship to speech being manifest? What can you say about the relationship to speech? But the proviso that I was intimating earlier is that it's not necessarily the case, although Lacan wants to say it is in Seminar 3, it's not necessarily the case that you can diagnose psychosis or psychotic structure through speech. It may not be evident. This is just discussions amongst clinicians, and certainly when I was training, that one shouldn't use that as a sole criteria for the presence or non-presence of psychosis. But nevertheless, let's develop the point a little bit more and try and do it with a little bit of nuance. We've seen then that neurotics cannot prevent themselves from conveying more than they intended. The relationship to speech and psychosis is somewhat different, argues Lacan, and it's different because of this assertion. For him, he says, and I think this particularly pertains to schizophrenia, the other, or the function of the big other, has been excluded from their speech. What does he mean when he says that? And I'm developing particularly on how Dany Nobus makes this point. When we say the function of the big other has been excluded from speech, it's important to be a little bit more refined to define what we're saying. It doesn't mean that psychotics don't have speech. You could say if the big other didn't exist for them at all, then speech wouldn't really work at all. Speech does operate at a certain level, but what Nobus is pointing to when he highlights this Lacanian idea that the other is excluded is that the otherness of speech, that dimension of the unknown, that dimension of the otherness of how I am heard, the dimension of the otherness of speech itself, that could be said to be lacking in psychotic speech. So what would that mean? It would mean that the otherness of speech is very much present in neurotic speech. And of course, in a way that helps us to recapitulate what we've just said. If the otherness of speech is in the speech that I'm speaking, then my speech goes beyond me. It implies things beyond what I meant to imply. It means that I might have slips. It means that I have unintended consequences and implications in my speech and that I can hear them, right? There is an otherness in speech. But if that dimension is not there, then there'll be several implications. One of which would be, Nobus puts it this way, that there will be a semantic shallowness to speech. There would be a lack of ambiguities. There would be a lack of uncertainties. The speech wouldn't reverberate back upon the psychotic subject in a way where they might say, well, I didn't mean to say that, or that's not what I tried to express. That element wouldn't quite be there. And I found a really nice quote from Dany Nobus, which I'll point to now, just to bring out that point. Of course, what Nobus does, good Lacanian, he roots this in a series of observations made by Freud, and as early as 1915 in his paper on the unconscious, and I'll cite a little bit from that. We're on page 9 of Dany Nobus's book. Already then, Freud had started to think about how we might be able to differentiate schizophrenia on the one hand from hysteria and obsessional neurosis on the other. And one could do this on the basis of speech itself. A nice kind of Lacanian point. Well done, Freud, you did a nice Lacanian thing. So here's the passage. According to Freud, says Dany Nobus, a schizophrenic patient's speech bears witness to remarkable meticulousness, with expressions often displaying a degree of artificiality, sentences becoming disorganized, and words getting strangely mixed up with the body. Schizophrenic patients appear to be using condensed speech because a whole series of thoughts find an outlet in single words, which consequently acquire massive meaning and become linked to bodily organs or processes. So this is an interesting observation. The condensed speech which becomes a stand-in for massive meanings and linked to bodily organs and processes. This doesn't seem to be speech which has the ambiguities, the multidimensionalness of neurotic speech. Freud continues, or Nobus continues, patients are no longer concerned about the actual things that words represent in a particular language. They merely relate to their verbal content. And I think this is a useful observation that within the language of schizophrenic subjects, the words being spoken relate to other words being spoken rather than, as it were, being moored to an agenda of pointing necessarily to things in the world. The Freudian way of thinking about this is to refer to the broken connection between word presentations and thing presentations. The broken connection between words operating as referring to things in the world and words being referred to other words, carrying on and on in this way without that referential relation back to the signifieds that they are representing. Nobus says one way of thinking about this, he gives an example related to him by a colleague, concerned a man who threatened to burn down the psychiatric clinic where he was working because the people there had left him out in the cold. In other words, what you could say is happening there. There's a very literalness to those words, a literalness which escapes the metaphoric dimension. Now, we're not saying that psychotic people and schizophrenic people can't use metaphors, although some Lacanians do sometimes make that implication, but rather we're saying that something about the dimension of their speech tends to the more literal. And a colleague of mine once mentioned this. They were reflecting some words back to a psychotically structured person who they were working with, and they mentioned the psychotically structured person hadn't used this phrase, the clinician did, The clinician said something like, well, the ghosts of your enemy surrounds you. And of course, he hadn't intended to do that, but this slightly freaked out the person because they didn't immediately grasp the metaphoric dimension of that enunciation. And in fact, that had more of a kind of literal impact on them, right? It didn't have that semantic ambiguity that often comes with neurotic speech. So let's bring that to a conclusion, maybe with this last brief quotation from Nobus, and then we'll end this mini session before turning to another. In Seminar 3, I'm now on page 14 of Nobus's book, Lacan speaks about psychotic communication. And here's the quote from Nobus. The exclusion of the other means that we have a semantic shallowness of language in psychotically structured subjects. In psychotic patients, language has not been adequately anchored. Rather than being firmly embedded, solid structure, it's free-floating. It's like a flat and permeable screen, implicitly referring to Freud's idea that in psychosis the link between word presentations, signifiers, and the thing presentations, signifieds, the thing that refers to, this link has been severed. Lacan defines this non-embeddedment of language as a lack of quilting points between the signifier and signified. In other words, you could say language operates very differently, and it's not being anchored in quite the same way, it's not conventionalized in quite the same way, which means a couple of things. It means it can be thoroughly idiosyncratic, it can be filled with neologisms, with words that the psychotic subject themselves makes up, and that it doesn't convey conventionalized meanings in quite the same way that neurotic speech does. Let's stop with that.